now.
All right. Hello. Sorry for the delay. We have some connection problems, and thank you for joining. So I am Dr. Ali Rezaie, and we work a lot on gut microbiome at Cedars-Sinai through medically associated in science and technology program. So I run the development of GI devices and also microbiome dependent devices to help with multiple diseases. And also I work on bioinformatics, which is how we break down the knowledge and the data that we get out of gut microbiome to see what can be done to help patients and also what's normal. On the clinical side, I run the GI motility program, and which with it comes seeing a lot of patients with irritable bowel syndrome, patients with GI motility disorders, and also patients with SIBO. So managing bacterial overgrowth becomes the bread and butter of my clinical practice, but as you know, there are a lot of cases that are complicated. So without further ado, let's go through the questions. There has been a lot of questions that has been submitted, so I'm going to go through some of the questions that have been repeated the most. I don't think I can get through all the questions. Probably have to set up more of these sessions to answer them all. So one interesting question that was brought up was the connection between rosacea and SIBO. So for those of you who don't know, rosacea is essentially the flushing that you get on the cheeks, and it's very common, more common in women. It can happen in the setting of pregnancy. It can happen in the setting of sex hormones and also some of the medications, but it can just happen. But there are multiple studies that have been shown the association between SIBO and also rosacea. Also, there has been associations between H. pylori and rosacea as well. But the link between SIBO and rosacea is rather strong, so it has been shown in case control studies, it has been shown in prospective studies, and also it has been shown that if you treat patients with rosacea, with rifaximin, that has led to improvement of rosacea. So that led to a concept known as gut-skin axis. That a lot of actually research groups are working on it to see what is leading for the gut microbiome to cause rosacea, for example. So the idea is that obviously bacteria can produce a lot of transmitters and neurotransmitters and also biomarkers that can affect the function of the nerves and also the vessels, and for example inflammatory markers they can produce, cytokines that they can produce, and that has been implied in the setting of rosacea, but we have not seen a direct link of what biomarker in SIBO can lead to rosacea, and that is an active field of research. And I have no doubt that there is some sort of biomarker that is being produced by the bacteria in the gut that is getting into the systemic circulation, and that is leading to vasodilation of the vessels underneath the face that is leading to rosacea. So now what that is, eventually that can be a biomarker and also a treatment target for rosacea, which is an interesting field of research. So in summary, is there association between SIBO and rosacea? Absolutely. That has been shown by retrospective, prospective studies, and also clinical trials. So another question that is coming up multiple times is the association between mast cells and SIBO. And this is, as you can imagine, it's a broad field of research. It's a new field of research, and multiple groups, including us, are working hard on it to see if we can decipher the association. So let's step back and see what the mast cells are. So we have soldier cells in our body called white blood cells, and these can be lymphocytes, these can be neutrophils. For example, neutrophils fight bacterial infections. Lymphocytes are implicated in fighting viruses and also producing antibodies. I mean, obviously, lymphocytes have been very hot in the last 2 years, considering the role with COVID-19. I'm not going to go over every category of white blood cells, but one of them are mast cells. So mast cells are essentially everywhere, and they are the cells that are involved in the allergies. They interact with the allergens that enter in our body. I like to resemble them to TCA agents. Essentially, well, you have soldier cells that go to war. TCA agents also are very important to allow who comes in and who can't come in, and those are the mast cells. So they see and sense some of the allergens, some of the antigens that they come to our body, and they react to it depending on what they consider appropriate to enter or not to enter. So this association of allergens and mast cells are implicated in multiple diseases. For example, asthma that we know is associated with inhalant allergens. Food allergies that we know that are associated with food antigens that we eat on a regular basis, and our body correlates with it. Now, we have seen multiple studies coming out showing that the mast cells in the gut and the interaction of us with the food allergens and also the gut microbiome are dependent on the mast cells. For example, there has been a study showing that, although mostly in mice, that if you have infectious gastroenteritis, and that infectious gastroenteritis can lead to changes in mast cells and also the sensitivity of those mast cells to food allergens. Meaning that the same foods that you were totally tolerant to, now you eat them, and these food allergens now after food poisoning can lead to symptoms of IBS symptoms like abdominal pain. And also they can sensitize the nerves in the gut, dorsal root ganglions, and that can lead to this motility and multiple abnormalities. For example, a good and big study came out in Nature that was discussing the role of food poisoning and then the sensitization of mast cells leading to abdominal pain that was published last year. Now, what is the role of SIBO here? So obviously, when you have food poisoning, it's a known fact that you get this motility. And that's one thing that we have shown in multiple studies in the past. And one pathway that you may know or you may not know about it is through the anti-vinculin and anti-CDTB antibodies. So in short, when you pick up an infection with gram-negative bacilli, such as Campylobacter, which is the most common pathogen to cause food poisoning in the US, or E. coli, which is most common in Southeast Asia or Mexico. These have a protein called cytolethal distending toxin. The name is not important, but that protein in our body can lead to antibodies, which are called anti-CDTB. But these anti-CDTB antibodies can attack another protein in our body, which is called vinculin. And vinculin is everywhere, including enteric nervous system, which are the nerves of our gut. So we develop autoantibodies against vinculin through molecular mimicry. So autoantibodies is when we develop antibodies against a protein that exists in our body. So it's auto. So we produce that against ourselves. So these autoantibodies can attack the vinculin in our gut, which is essential in the function of enteric nervous system, and that leads to this motility. And now when there is this motility, there always comes a dysbiosis, meaning that the microbiome starts to change. And that's essentially simple because the health of microbiome in our gut is dependent on how the gut is moving. If the gut is not moving well, obviously some bacteria prefer that scenario and they overgrow and they kick out or suppress the other bacteria that are supposed to be there. So a classic example of it is small intestinal bacterial overgrowth, small intestinal fungal overgrowth, and what happens is that the colonic bacteria that on a regular basis come to the small bowel, for example, they can't be kicked out back into the colon using the migrating motor complex or housekeeper waves, because they're affected with anti-vinculin antibodies that were originally have been caused by a food poisoning. Now, so let's put those together. So we know that food poisoning can lead to bacterial overgrowth and dysbiosis. And we also know that food poisoning can lead to mast cells literally going crazy, becoming hypersensitized. So these two can go hand in hand. And now how these two can potentially interact with each other, we don't know exactly. So we recently published a paper that showed that patients, for example, with mast cell activation syndrome have higher rate of bacterial overgrowth. Now, that doesn't rule in any causality. That doesn't mean that mast cell patients or MCAS is leading to SIBO, or SIBO is causing mast cells. They are coexisting, but we don't know which is the cart, which is the horse. So, and that is another field of research that we are working on. Now, this makes management of patients who have MCAS and SIBO a little bit tricky. Number one issue is the diet, right? So we know that SIBO patients, we put them on a specific diet, at least in our clinic we do that. We call it low fermentation eating. And patients with mast cell also need to be on a specific diet that helps their symptoms, generally low histamine diet. And now mixing these two becomes a little bit of a tough scenario, although it's not impossible. And that's something that you definitely need to seek help from a dietitian to see how you can work this out. And make sure that you don't put yourself on a restrictive diet forever, because extremely restrictive diets are not healthy in long run. So that's very important. And that's one of the reasons we have been talking about low fermentation eating, because that's a relatively less restrictive diet, and it allows you a bunch of food items and food ingredients that are healthy to keep you well nourished without going completely crazy on restricted diets. It's easy for me to tell patients, well, okay, go on rice and chicken, and that's all you eat, and you'll feel better. Well, yeah, but that's not feasible and doable in long run. So, this is a good point to give a shout out to Robin Berlin, a dietitian who we have been working long term with patients in our who have SIBO, and also Christina Hauser, who was a patient of our clinic and had SIBO. And these two actually linked together, and she's a chef, and Robin is a great dietitian and also a chef. And they have put actually a book together to help patients with bacterial overgrowth, making tasty food that without affecting their quality of life significantly. So, and also it has like appetizers, it has actually even drinks, how to make it, and also entrees. And so I highly recommend that book. And Mark and I wrote a preface for it, which is I think it's coming out on 12th of April. So that's we're very proud of that. A patient of ours and also our dietitian linked together, and they could publish a book all about how to get your life back if you have bacterial overgrowth. So that's one thing about SIBO and mast cells. Another issue is that, okay, how do you treat patients? So there are multiple studies that are focusing on how to treat patients with mast cells. And there are multiple studies, obviously, that are working on how do you treat bacterial overgrowth. The good news is that usually these treatments do not interact with each other. And in fact, they work synergistically and help each other out. One thing is that patients with mast cells have a lot of drug allergies as well, so you have to be vigilant about that. That's starting high dose of a medication may not be tolerated well in these patients, so you have to be careful and work the dose up slowly to help patients. But generally speaking, medications that we use in bacterial overgrowth are well tolerated in patients with MCAS as well. Although obviously in severe cases of MCAS, a lot of medications can be tolerated well, and that's when you definitely need to be followed by a healthcare provider who is well tuned with mast cell disorders as well. So that's the part that I wanted to talk about mast cells and bacterial overgrowth, and that's a big topic and constantly changing. If you're interested, we published a primer for gastroenterologists in Digestive Disease and Sciences journal, and that came out last year, and that has been highly cited. So that's a good paper to read to get a sense of what is mast cell as well, and how do you treat that. There was a few other questions that they're asking about the connection between bile and SIBO. So just quickly going how bile acids work. So our liver produces bile acids, and these bile acids go into the bile ducts. And these bile ducts connect to each other and become common bile duct, and eventually that bile makes its way into the duodenum. And if there is you're not eating and bile is not needed to be pushed into the duodenum, then some of that bile comes back into the gallbladder. It gets reserved there, and that's well, it's gall. So essentially, all the bile is reserved there. So when we eat, when food goes into the duodenum, and bile acid gets pushed into the duodenum, and that can happen by activation of the bile production, or the body knows via some biofeedback that we have in our body to contract the gallbladder and push the bile inside the small bowel. What does it do? It breaks down fats, so it helps to digest fat, and that includes food that has cholesterol, food that has a lot of fat, and also fat-soluble vitamins, including vitamin A, vitamin D, vitamin E, vitamin K. They're all dependent on this bile to get absorbed, and we do need it. It's very important. So interesting thing about bile is that we have a recycling system for bile in our body, because it's not easy for our body to produce bile. And the recycling happens at the end of the small bowel. End of the small bowel is designed to reabsorb about, almost, depending on what source you read, but about 95% of that bile, and that gets absorbed into the system again, and gets re-secreted into the bile by the liver. Now, the interesting part is that some of this bile, when it goes throughout the gut, gets deconjugated by the bacteria. So if you have excessive amount of bacteria inside the small bowel, a more than usual amount of bile in the small bowel gets deconjugated, and that leads to bile acid malabsorption, meaning that these bile acids can't be recycled in the small bowel, and then they end up into the colon. Now, when bile gets into the colon, the colon is not designed like the small bowel to tolerate the bile acid as well. It gets a little bit unhappy, and that can lead to diarrhea. So now, bile acid malabsorption has three components, three types. Type 1, which is when you have lost your terminal ileum. Now, this is because of the inflammation in that area, famously happening in the setting of Crohn's disease. Whether you have had surgery in that area, for example, in the setting of Crohn's disease, you have had that section removed, so the bile can't be absorbed. The type 2 that can happen in the setting of relatively rare abnormalities, genetic abnormalities, which is doesn't allow the reabsorption of the bile. But one of the most common types are type 3, and type 3 is the most common cause is bacterial overgrowth or small intestinal bacterial overgrowth, which is the mechanism that I just explained, that you have excessive amount of bacteria, it deconjugates the bile, and it can lead to bile acid malabsorption and bile acid diarrhea. So it's interesting that if you treat bacterial overgrowth, then you suppress that pathway that helps with the diarrhea associated with type 3 bile acid diarrhea. So there is a very close connection between bile and bacterial overgrowth. And I have to give a shout out to sort of a group that pioneered this research from Japan, from Shindo Group in early and mid 90s. Way before me starting research. And then what they did is that they did a very interesting study. They put tubes inside the jejunum of healthy controls, and also almost 100 patients with scleroderma and patients who had significant possibility of overgrowth. They suctioned the bacteria out of the jejunum. Remember, this is in 90s. We didn't have a lot of fancy tests and techniques to get the tube into the small bowel. They suctioned that juice out of the small bowel. They got the bacteria in the small bowel. They poured from healthy individuals. They poured that juice from patients with the scleroderma who had bacterial overgrowth on the bacteria, and they saw in vitro in the lab that they are deconjugating the bile, and that was actually the eureka moment at that point that this can happen. More importantly, they didn't stop. There is an antibiotic that actually we don't use anymore. It's called chloramphenicol, and they tried that, and they showed that this process can be reversed. And that was, again, another big piece of information there that pushed our understanding about bile acid malabsorption and SIBO. In fact, actually, that's another field that we are actively working really hard to decipher that, the specific interaction of bile acids and bacteria in our gut. We have a few minutes, so I wanted to talk one question here: that can intermittent fasting help MMC and therefore SIBO? Absolutely. I mean, part of the low fermentation eating is not just the diet. It's in fact actually trying to maximize number of housekeeping waves. So housekeeping waves, which are waves that happen every 90 minutes to 120 minutes, so roughly every 2 hours in our small bowel, and there are housekeeping waves. They just sweep the small bowel and dump everything into the colon. They happen while you're fasting. They don't happen when you're eating and you're in the feeding phase. And the feeding phase is when there is food in the stomach, and stomach is grinding and mixing food with the acid and the enzymes. And that process takes about 2 to 4 hours after eating, and then you enter the fasting phase. So that's why we recommend that when you're eating throughout the day, to give your body about 5, preferably 6 hours of time in between each meal, so you get into those fasting phases, so migrative motor complexes start to kick in. Also, overnight, you need at least 8 to 10 hours of not eating, so the migrative motor complexes can kick in and help you. So definitely fasting can help with migrative motor complexes, but obviously we don't recommend prolonged fasting. because at the end of the day, you need to have a nutritious food as well. So that intermittent short fasting is part of low fermentation eating. That's for those of you who don't know, our book that Mark and I wrote, it's going to come out on April 12th, and in there we have a whole chapter talking about how to what is housekeeper wave, and also how can you help with your housekeeper waves, whether it's through fasting or what medications are out there that can help with the housekeeper waves, and how you can fight with bacterial overgrowth. And now these housekeeper waves are integral in fighting with bacterial overgrowth. Why? It's clear, because you need these waves to clean your small bowel, the whole 20 feet of small bowel, and keep the bacteria in balance so they don't get overpopulated inside the small bowel. And without that, obviously, you're at higher risk of small intestinal bacterial overgrowth, in small intestinal fungal overgrowth, and the dysbiosis that happens in patients with bacterial overgrowth. So that's integral in management of bacterial overgrowth. Now, the problem is that sometimes these housekeeper waves are significantly affected in bacterial overgrowth patients, in SIBO patients. So just fasting is not enough. So that's the time that you need some medications to modulate these waves to help them, to help the small bowel to push things forward. So, so with that, let me just see if I have another question that I can jump on quickly. So one quick question is that whether there is an association between H. pylori and SIBO. There are actually several studies that have been shown the association, and there are also multiple studies showing that H. pylori leads to dysbiosis. I mean, by definition, H. pylori itself is a dysbiosis. That's actually interesting a concept, because a lot of patients with H. pylori do not have symptoms, and we know that H. pylori patients do have dysbiosis. So this whole concept of asymptomatic SIBO and dysbiosis is also a up and coming concept to see what needs to be done in those patients, and also what is the spectrum of disease in bacterial overgrowth. So there's definitely a link there, and more and more we're understanding about that. So so sorry to be a few minutes late at the beginning. I'm pretty sure we have to set up more sessions to talk more about this. Fantastic questions. I got through, like, I think 1/4 of them. Sorry about that, but hopefully we'll get to more questions on the next live session. So hope that was helpful, and follow us on Twitter, the MAST program, and also our individual Twitter, and also Instagram. We try to be active and update you on the newest research, and have a great day. Thank you. Bye-bye.